Hi, everyone. Sayer here, and I'm just really honored to be speaking with Joy Fritz, whose work I was exposed to through her having a background as a death recording clerk and helping to shed light on some of the questions that have come up around the way COVID deaths have been coded and certified in terms of death certificates. And one of your presentations, Joy, really opened my eyes to a lot of uncertainties around what actually, that death certification process involves, whether it's really grounded in science or, is it open to interpretation and opinion. And I was recently pretty flabbergasted to find that it's very clearly, it's a medical opinion of the physician, if it's a physician who's, doing this kind of coding. And I would just love to get more insight from you, because in this moment, there's so much fear around new cases and COVID death statistics, and a lot of question over what does it mean, for example, that recently the CDC published an update on their provisional death count, stating that only 6% of those deaths that were, calculated were a result solely of COVID-19 being listed as the underlying cause of death. And so there's been a lot of question. Even the president retweeted somebody's tweet about it, and then he got censored on Twitter, which was pretty shocking. And so it so helps to have someone who actually knows about how this works. And again, I'm just really happy to have your time. So yeah, I would love for you to shed some light, anything that comes to mind. I'm just ready to learn myself.
Well, thank you, Sarah. I really appreciate just having the chance to actually meet face to face, even via Zoom. And I have appreciated the research, like I mentioned before. On GreenMed Info was one of the first resources that really gave me not just their assessment of kind of, some of the debate that was going on around, health and infectious disease and everything, but thoroughly cited. And I just appreciated that so much about GreenMed Info. I mean, you can't find that in mainstream media, which is ironic because they're supposed to be unbiased and actually direct source journalism, and they don't even cite their studies that they talk about. And you guys are just so careful about citing everything and really offering the argument as it progresses and not just being inflammatory. So I've really appreciated what you guys have given to me and gifted to me in my research with trying to find the truth in health data and health decision making. So I really appreciate you guys, and it's an honor to spend some time and chat about this. So yeah, and I came out to initially a few years ago to just share my observations on trying to make a decision for my own family about the flu shot, and realizing as I was looking to try and find out how many deaths the flu shot causes versus how many deaths the flu causes, that the data wasn't even there to really make that decision. And it wasn't there because I was creating it. I mean, I was a death recording clerk, and I understood exactly why that information wasn't there for me to find. So I actually started there about 2 years ago and kind of offered a little expose on how death certificate recording would not help people make that decision because of the inherent flaws and biases that are already in death recording. And then now COVID has kind of exacerbated that, that annoyance that I have with people looking to, and scientists and experts looking at our mortality statistics as they're provided by the death recording process, which I was a part of for 6 years, and trying to use that as some kind of scientific bludgeoner to make their point either way. And it's just not, it's a broken system from the very beginning, where we try and get information about the death, which is what I did. I was a mortuary personnel death recording clerk that would, when a death happened, would reach out to the doctor and ask, send them a worksheet, have them fill it out, and the process starts. And then you type that in. I was certified in the electronic death registration system in California, and you input the information, you send it to the local vital records registrar's office, and then the government gets a say in whether those doctors, those causes that the doctor provided is allowed to be put in the way that they put it on the death certificate. And so then the government gets to say, yes or no, or approve it or reject it and send it back and ask more questions. So there's this whole process that goes back and forth between, these vital records registrars, information grunts like me, the doctor or the coroner, and there's just this whole run around. And meanwhile, the family is waiting to be able to have services. So it's a really pressurized situation, very time sensitive. It's no place for a careful scientific investigation. So we're just, when we do death certificates, there's not really for the vast majority of people, you're not getting a thorough, scientific, unbiased investigation of what caused your loved one's death. That's not what you get on a death certificate. You get whoever the attending physician was at the hospital, or your primary care, or your hospice doctor, and their medical opinion as it conforms to the vital records registrar's, their book of what's allowed, or the coroner, if the coroner is involved, which is very unusual. But if they are involved, then they get a say. But even the coroner has to capitulate to the vital records registrars. So when I found out that this NVSS, the National Vital Statistics System, sent out this memo for guidance back in March. It was the end of March. It was like one of the last days of March, I think.
Yes.
And they were explaining how death certificates for COVID ought to be done. I really looked at that and saw that there were some problems, some very problematic things happening then. And then they instituted a system of manipulation then. And I kind of went over that in the video, and I explained probably too long. I went my Facebook video is like an hour and a half long. And then I tried to shorten it down on my YouTube video to like 20 minutes. But, it's a long, boring explanation of why this memo, together with how we do death certificates, not just from my perspective, but with all this documentation, how we do death certificates it's not appropriate. It's manipulative of scientific, of what anything that's left of the scientific process of death recording. And it's not going to help us actually understand what caused these deaths. And now we're seeing people trying to find the truth in death data. And I think that's why that article went viral about the 6% versus the 94% on the CDC's, information. It went viral because people are it's not making sense to them. And there's so many stories coming out of, deaths being called COVID deaths that they didn't have any real evidence for it being a COVID death. And there's just so many stories you'll find of people saying, my loved one, they said it was a COVID death, but I know what it was. It was this, this, and this, and it wasn't a COVID death. So we're seeing all of that, and we're needing a more logical explanation and some actual unbiased numbers. And so I think people were really hungry for unbiased numbers. So they're like, oh, look, the CDC is adjusting things. Yes. And they're going through their data, but we misunderstood what that data was actually saying. So I kind of clarified that recently.
Yeah, if I could add that guidance that was released through as a national vital statistics system, is that right?
Right.
That was really mind-blowing to me too. And that's how I found your work, because when I looked at it, I was shocked to find that they didn't require testing or any confirmation that the person they're saying is dead from COVID actually, meaning suspicion was all that was needed, and that was the language they used. And I thought that was diametrically opposed to what I thought happened on the end of someone who is in your position. And so clearly you helped elaborate on how that's actually not the case. And that's what led me to your work. So it's very helpful to hear you explain this in greater detail.
Yeah. Well, and specifically on that, the 6% versus the 94%, the problem there is that and I kind of went over this in my post on my public page on Facebook, but what's interesting about people looking at that and saying, oh, look, on death certificates, there was only 6% of them said COVID-19 only. So that means only 6% of the deaths happened because of COVID. And I want to clarify that if I can. Yes. So what a death certificate, the way that they defined comorbidities and how they organize their data in that, if you click on that provisional data, and what they defined as comorbidities was literally, it wasn't a underlying condition, which is that's another phrase that would be more appropriate, I think, when we're talking about people with diabetes or Alzheimer's or, a history of stroke or, these different things that can really lead to a decline in health and make you vulnerable to any infection, COVID, one of them, but any infection. And so that would be like, we should probably call that underlying condition and not comorbidity, because medically speaking, a comorbidity is just something that is together with and that sickness. So a comorbidity with COVID would be a respiratory failure of some kind, or respiratory distress. Sepsis can happen with any infection, with most infections, but COVID is one of them that can cause sepsis. So these are they're together with the sickness, and that's what comorbidity means. Okay. And so the CDC was being very they weren't really explaining what comorbidity meant, and so it's a very broad category of just meaning sickness together with. And one of the things that would always be almost always be on death certificates is the doctor is supposed to kind of line up the timeline of, the most immediate thing that happened, which would normally be like cardiac arrest or respiratory failure. And that would be on the first line of part 1. And then under that is something that happened a little farther away, maybe a couple of days before that, their kidneys started failing, right? So then they write kidney failure on line 2. And then line 3 or 4 would be what caused all of this, right? So was it chronic kidney disease? Was it an infection? Was it, just a decline in health from stroke? What is it that led to their decline that caused their death? And so in that place, they would put something like COVID-19, MRSA, Alzheimer's disease, stroke, things like that. So it's whatever is listed on the last line in part 1 of death certificates. That's what's recorded in our mortality statistics and what's considered what causes death.
Can I ask
Did you have a question about that?
Yeah, because there's an example that I can actually share, which they show, okay, this is based on the guidance from the World Health Organization and NVSS, that according to the new emergency ICD code U07.2, where no virus is proven to be present, but only suspicion, that they can put down suspected COVID-19 as the underlying cause of death, and that will then be reported through the CDC as a COVID-19 death. So that was the part that was really shocking to me, to see that, all that had to happen. And I understand that for a physician writing this up, it's a medical opinion anyway. So, yes, they use their intuition, they look at symptoms, and then they also clarify that because coronavirus is a huge family of over 100 viruses, that if there's any suspicion it's coronavirus related, they should always mark it as COVID-19. So that was another thing that was like, really? Like, they're acknowledging that there's no real way to prove it's the strain COVID-19, but they should always code it as COVID-19 to reduce confusion. So I just wanted to ask you, is this unusual, or is this what usually happens?
I think that it would be, it's I think on a common sense level, and I think that this should hit doctors wrong, that if you have someone with pneumonia, that you write down what strain of influenza or coronavirus or rhinovirus or, whatever is causing that you would actually pick a strain randomly. And it's not randomly. There are, they obviously, we're in a pandemic right now, or, we're learning about this new virus. And so it's a belief that they have right now that it's likely to be COVID, right? So, and I think that we have to step back and realize that mortality statistics are very much just a historical reflection of the medical beliefs at the time, especially if you don't have laboratory data to back it up. They're going to go with whatever the popular medical belief is. So as long as we are creating, and public health officials are creating a belief in the medical community about something, then there are going to be more COVID-19, death, things written on death certificates. And the doctor has the right to write whatever they want. They have to back it up in court. If that legal document is taken to court, they have to show some kind of proof. But it really isn't, and I think this is a serious misunderstanding, both in the academic community and in the civilian community, is that we think that mortality statistics are facts, that there are these scientific facts of death, and they're not. The only scientific fact of death is that that person's name died at that time, at that place. Wow. But the cause of death is not a scientific fact, and it says so in the manuals, the coroner and the physician manuals from the CDC. It says that this is a medical opinion. Yeah. And it even says in the manuals, medical opinions change from provider to provider. So there's a freedom to have different medical opinions. And there were so many times where I sent death certificate worksheets to multiple doctors for the same patient, because we were rushing and we were trying to find any doctor that would sign the death certificate. And as long as you attended over the patient in the past 6 months, you're allowed to sign. So we would send it to a bunch of different doctors to see who could get back to us the quickest, because the family wanted to have the service right away. And I would get worksheets faxed back to me from, the kidney specialist, the cardiologist, and the primary care physician, and they all had different causes of death on them. Wow. So they're allowed to have differences in opinion of what was the primary cause of death. And that's why I think that it overstepped their role. NVSS overstepped their role by telling doctors that, if the person tested for COVID, or if there was they suspected had COVID, that should be the underlying cause of death, or it would more likely than not be that. That's an overstepping of their jurisdiction to tell the doctor what the probability is, when we didn't even know the probability back in March. Like, I'm sorry, but how dare NVSS start creating beliefs in the medical community about probability of what causes death for physicians that have been attending over these patients sometimes for months or years, and they know that this person, if they would have gotten any infection, they would have died. But now NVS is telling them, if they test for positive for COVID, or you think they were exposed to COVID, now that's the only cause of death. That's their underlying cause of death. And that takes away the freedom of the physician to actually have a medical opinion that is his own or her own. And I think that's kind of where the manipulation happened.
Yeah, if I could add, it's amazing. Verbatim, you're stating what I found on the CDC's website and reviewed today, which is their guidance for certifying deaths due to coronavirus disease 2019. April the 16th, they did an hour-long presentation. I watched the entire thing today. At minute 13, it said no such thing as an objective medical cause of death. They say there is no such thing. It's all opinion. And then they say at minute 19, 13 seconds, that COVID deaths are assumed. They're asked to make an opinion if they think or believe it's the cause. So there's no, there's no pretending that this is anything but an opinion based on the present beliefs and thinking of the time, which of course, with the mainstream media blasting 1 trillion times over that COVID is killing all these people, and we're all, shuttered in our homes. And then let's see, they said, same thing you said, suppose that something is the case on the basis of probability. So yeah, everything you're saying is right from the CDC's own guidance on how to code this. And again,
interesting that they cite probability when they were instructing, physicians to put COVID more often than not as the underlying cause of death back in March, end of March and April, when we didn't have probabilities yet. We didn't really, we didn't have good data. That's why they locked down, because we didn't understand the disease fully yet.
Wow.
And so for them to create a belief about probabilities before we have the data on probabilities is proof itself that that they're manipulating medical beliefs to go a certain way and data. And now we have mortality data that has been influenced by the NBSS's opinion back in March about this. And now we have data that the doctors think is scientific because it's mortality statistics. And so now they actually think that they have scientific fact and that increases their idea that cases of the elderly with pneumonia are going to be COVID, because now they have what they think is scientific facts in mortality statistics backing that up. But that was actually created by an assumption of probability and not the actual reality of probability in the first place. So it's just perpetuating its own cycle of, a belief system based on assumptions and not actually unbiased data.
Well, thank you for that, because, given I didn't know the story about how you got into helping people understand this side of how this all works was with trying to figure out like the flu vaccine and, probabilities around that. And one thing that I'm concerned about, I'd love to know your opinion on this, is, given that the early trials on the COVID vaccines, which are of course experimental in part also because they're RNA-based vaccines, which have never been approved for human use previously, the reactions they induce are often fever and chills, which are listed at the CDC as one of the primary symptoms of COVID infection. So I'm concerned that when they do release the vaccines into the public, a lot of the symptoms will be identical to what they're saying are COVID, and then they'll identify it as a second wave. I'm wondering if you have any opinion on that, because I think that's something that at least I'm concerned about.
Well, so one of my my nerdy hobbies is I love reading the disease surveillance manuals for different infectious diseases. I find them, they're good reading. And then you actually can find the research at the CDC, finally find it, not just on the main page, but like, how do you justify that truth claim or that truth claim? And then they actually have the thing cited, and you can actually go and look and be like, oh, well, you cherry picked from that study to try and make that point. That's kind of a long shot. So I love reading the disease surveillance manuals. It just gives a lot of context too, historical context, and it helps you see things from a provider's perspective and how, because they literally give instructions on, this is what we know about the disease. This is, the treatments. This is your diagnostic criteria. So it really helps you understand things from the medical perspective as well. And one of the ones that was shocking to me was diphtheria, when I was reading about the diphtheria, disease, and what it said in the diagnostic criteria to rule out diphtheria is to find out if the patient had a diphtheria shot. So you're literally ruling out something that they could have just based on their history of having a shot or not. So you're assuming that they're not part of the population that didn't respond. We have, primary and secondary vaccine failure that causes, people to not respond. Some people don't respond to the vaccine. So maybe they didn't get their antibodies up for it or whatever. And so they didn't get protection. And maybe they do have diphtheria, but the doctor's going to say, you don't have diphtheria. I can rule out diphtheria just based on your history of receiving the DTaP vaccine or the Tdap vaccine. And so that's problematic when you look at what could happen with COVID, right?
Yes.
Which is that if you get the shot and the diagnosed with COVID, even if you get COVID, or this could be a possibility as far as diagnostic criteria goes, is that the doctor's now going to rule out, because of their belief in the vaccine, just even though there's not a lot of good data, and this is a rushed vaccine, and it's very experimental in a lot of ways, the doctors are going to think vaccine equals prevention, so you can't have COVID even though you have all these COVID symptoms rule out COVID, done, let's test for other things, just based on your history of receiving a vaccine. So
Yes.
we already see that that's happened with other infectious diseases, that the diagnosis gets changed just because of the medical provider's belief and not because of laboratory testing and things like that. So I think that that's that's something to look out for in the medical community's belief system as it develops once the vaccine comes out, whether they're going to be basing it on whether they're going to be sending out the person for testing or not, purely based on their history of, vaccine uptake.
Great. Well, thank you for that. So I guess one of the things that still is a question that I would love for you to give us some reflection on is when it comes to the CDC's updating of their provisional death count and their statement around 6% of those, who died from COVID was solely written as COVID on the death certificate. What does that mean ultimately? Do you have an interpretation?
As a death recording clerk, it means a few very different things to me reading that.
Okay.
It means the doctor was either very lazy, and there's quite a few of those where the doctors they're lazy, they don't have time, whatever, and so they're just gonna, or they're beaten down. That was another kind of doctor that I had to deal with a lot, where they got so many causes. They would give a really good death certificate of this happened, there was a fall, there was this, and then the health department would come back and say, you can't say there was a fall, otherwise that's a coroner's case. And the doctor would be like, fine, take out the fall and just put in this. And so then they would go back and the health department would say, no, you can't put in that wording, you have to put in this. So the doctor would waste so much time going back and forth, and the family would get upset because now their services have to be moved because the doctor didn't cooperate or they didn't give the causes that they wanted. And so the doctors get beaten down over this process of back and forth. So they'll get I call it, I'm being a little mean because I'm calling it lazy, but it's also just beaten down. You're just beaten down by the system, and you're like, I know how the system works. All they want is this underlying cause. That's all I'm gonna write. I'm not gonna actually give like the timeline of what happened. I'm not gonna give comorbidities. They don't even care about that. They just want the underlying cause. The record will be approved. It'll be off my desk. So to me, there's a very kind of mundane reason for COVID-19 being the only thing written on a death certificate. Because of that population of doctors. They don't have the time. They just want the death certificate off their desk. So kind of but also I think that there could be in that group, the deaths that occurred that were they didn't have symptoms leading up to their death that were in line with COVID, and they did postmortem testing, which is like, why are we doing postmortem testing for COVID-19 and not for every other infectious disease?
Yeah.
Like, our elderly have been dying, and this is something that really upsets me because I saw people talk about hospices and nursing homes that are having 7 or 8 of their people die of COVID in 2 weeks. And I'm kind of back here like, we had people, I would get calls from, for 5 or 6 new cases from the same nursing home in a matter of a week. And we're not the only mortuary in town. So there was more people dying in these nursing homes than even I received. Nobody cared. Nobody tested them for infectious diseases or looked at their medical records and said, why did, 7 or 8 or 9 elderly die in the same nursing home in the same 2 weeks? Nobody cared before. Nobody tested cases post-mortem.
Right.
And all of a sudden now we're testing cases post-mortem. It's like, well, it's really nice that you guys care now about what's killing the elderly, but that doesn't make that data equivalent to, it doesn't actually help us form true beliefs about what infections have been and what things have been killing our elderly in clusters before, because that was happening before. So, and I'm sorry, I forgot, because that always bothers me, that we all of a sudden care about our elderly and what's killing them now and these infections when they've been dying from infections constantly before and nobody cared. But what was your original question? I got off track there.
No, you're good. That was helpful. I guess what I'd like to do is, it's almost like a thought experiment, because like there are a number of causes of pneumonia we know of. Many of them are classified as infectious, and then there's chemical induced pneumonia like symptoms and
healthcare acquired pneumonia. And how do we discern between healthcare acquired pneumonia and COVID pneumonia?
Yeah, like So, because we know that with COVID-19 tests, there have been a lot of false positives. In Florida, actually, there were 400 plus laboratories that reported 100% positive on their tests. So we know that not all the tests have been accurate, but even in the absence of a positive, PCR COVID test, all they still need is suspicion. So they never even really needed confirmation or laboratory validation. But so if someone has pneumonia, um, that's going to be listed as another cause, right? Not a
That would be
comorbidity.
a comorbidity.
That's
Right?
part one. Would it be part
That
one
would
or?
be on part one. That would be kind of like their
Mm,
progression of symptoms,
gotcha.
basically, from the primary cause
Right.
or the underlying cause.
Yeah, like so for example, they may have had a history of COPD and heart disease related to a lifetime of smoking cigarettes. And over time, because of the regenerative capacity of the body to heal tissue, at some point those stem cells just can't function any longer, and the body does succumb to a lifelong culmination effect of toxicity, et cetera, or just age, because that's, the majority of those who died of COVID-19 were older. So it's just amazing to me to think that none of that is accounted for, and that everyone who died with those sorts of indicators of pre-existing conditions were just written off as being killed by COVID-19, which of course would justify the mask wearing, the social distancing, the shutting down of businesses, the staying away from each other. But it doesn't seem to make much medical sense to me, based on especially the fact that they haven't identified a virus and differentiated it from the virome, which has trillions of viruses. So the whole thing really kind of gets confusing, and or seems like some kind of conspiracy ultimately against the truth, which is that there is no way you can prove that COVID-19 caused anyone to die. So that may be going too far down the rabbit hole, but that's what came to mind when you were talking about that.
Well, and let me just offer something from the last time that they decided. This is the report of the panel to evaluate the U.S. standard death certificates. This is basically the group that comes together, or is supposed to come together, every 13 to 15 years and see, should we change anything about the way that we're recording deaths? Is there any more boxes we should put on there, anything like that? And the last time they met was in 2003, which is more than 13 years ago. So they're behind a little bit, but they said, I was specifically looking for, I would love to have checked off more information about the medical record on the death certificate so we can get contextual information. And that would, I think, help create more accurate, public health beliefs. But so I was kind of looking for, when did they make that decision? And you're literally looking at like a transcript when you read this. It's like 300 pages. It's a transcript of the meeting, and it's the nerdy stuff I love. And so on page 139 of this, they talk about risk factors on a death certificate. And they go over some possible things they could add to a death certificate. Like, did alcohol use contribute to death, right? Maybe smoking contribute to death. Was there a history of substance abuse? Did the death result from a prescription medication problem? Was contagious disease present at time of death? That's one of the questions, the bullet points. Their decision was no, don't add that as a possibility, because it's just a risk factor. And we want the death certificate to just be about causes of death, not to be about prevalence data. But they've just turned COVID-19 mortality data into prevalence data. Who is dying with the presence of COVID-19 in their body, or suspicion of it, or whatever? So they're turning death data into prevalence data for COVID-19, but they specifically said back in 2003 that they were asked, can we get some more prevalence data onto death records so we can get a better understanding of risk factors for people? They said no. They said currently only significant conditions contributing to death are collected. These risk factors do not have to relate to the cause of death. In previous discussion of risk factors, the subgroup agreed that it was important that there be a direct connection between the conditions and risk factors and the cause of death. So it's not that there was a suspicion that there was COVID-19 there, or that the person tested positive. That shouldn't actually matter. The direct connection to death ought to matter in the mind of people that decide what goes on our death certificates.
Oh, so meaning like if someone was asymptomatic, for example, or there was a false positive test, etc., that would be an example where, you know, it would sort of bring the attention more to the causes that would be more obvious, you're saying? Is that right? Or
yeah, so if you, what's happening right now is I'm actually I'm 6 weeks away from having our baby, right? And one of the things that so I'm pregnant, I'm a little chubby right now, you know, the 3rd trimester plump going on. But one of the things that I've been looking into and hearing about is that a lot of hospitals are requiring testing either before you go in as a pregnant person with no symptoms.
Wow.
They're requiring testing in order to be admitted to the hospital to find out if you're COVID positive or not. Now, as a pregnant person, if I go into the hospital and I have my baby and I tested positive, then I die from some complication that happened during birth or after birth or something like that, they have this test that was not indicated for me to take in the first place, that shouldn't even be on my medical record or be a consideration of my factors.
Yes.
And that could be, the doctor could, depending on his belief system, say, well, it was the COVID-19, it was, you know, SARS-CoV-2 that really put her in a position that she didn't recover from hemorrhaging or this or that. And so he could blame it on COVID-19. That's his medical opinion. He's allowed to do that. But there would be no indication for me to have taken that test in the first place. And I could have died. And if I just went along and died from other reasons of, you know, their malpractice or, you know, my own stuff, then I would have had a more accurate death certificate, I think, you know, according to my belief system. So, and what I think medically about the connection to death, the direct connection to death, right?
Yes.
But because we're testing everybody going into a hospital right now, we're testing people regularly that aren't indicated for it. We're testing people just as a monthly or every couple monthly kind of thing, maybe in nursing homes. Now you are giving doctors data and asking them to create and really tempting them towards a diagnosis that is not based on symptoms. It's not based on, you know, actual respiratory issues or, you know, the different whatever what's going on with COVID. They're not actually coming to that probabilistic conclusion themselves. They're being given this prompting of, well, there's already this laboratory test done and they're already positive. So, you know, depending on that doctor's beliefs, that could be a COVID death. So I think there's some problems with
it's hugely helpful because, you know, what I'm thinking a lot about these days is the role of iatrogenic causes of illness and death, because someone who would have been, you know, certified as dead from COVID could have been an elderly person, might have been on 12 medications, a typical case of polypharmacy. And it's so convenient to blame an invisible particle, maybe one that wasn't even accurately tested or not tested at all, for the death of the patient, when it absolves liability, culpability, you know, which would otherwise be there. And then the psychogenic aspects of being so terrified by this virus and causing all types of adverse effects, because those two things combined, to me, might help explain what appears to be the excess deaths that the CDC has been reporting. Because when one points out that, okay, maybe COVID-19 wasn't involved in the 181,000 deaths that the CDC claims it was the cause of, then what is the cause of the excess deaths? And that's a question that I don't know if you have any answers for, but I've been suspicious of that being related to all of the, you know, ventilators that were maybe used out of fear that they, you know, were necessary when in fact they weren't, and, you know, all the things we're kind of referring to. I don't know if you have an opinion on the excess deaths that the CDC reported.
Right. So there's actually a couple things. So first, I'll talk about just real quick on excess deaths.
Okay.
I actually looked into that when I was looking through the provisional data, and there's an asterisk by basically the expected number of deaths, there's an asterisk. And that's based on the 2017, 2018 death data, right? So you look down on the asterisk and it says based on 2017, 2018 deaths that happened, how many happened in that year, right? And so I looked at that data, and then I asked the question, okay, you're going back 3 years. What if we go back 3 years again and compare between 2017, when there's no pandemic, and 2014 and 15, when there was no pandemic, and whether there was a jump in excess deaths from 2014 to 2017, and what that rate was, or what that increase was. And I forget what it was. It's on my public page. I posted on my public page the mathematical equation, but it was there was something like 180 or 186,000 excess deaths from 2014 to 2017.
Oh, wow.
We've currently, when I did the math, I think it was a month ago or so, or 2 months ago, we were at 100, we're projected to be at like 100, if we have a 5% increase in our deaths by the end of the year, we will be at 140 something thousand excess deaths if we stay at 5% increase from 2017. That means we will have 40,000 less deaths in the 2017 to 2020 bracket than the 2014 to 2017 bracket. So again, context is super important. You got to look at what they're talking about, and not just the last 3 years, but historically, what have been our jumps? Have there been kind of ups and downs? You know, let's get some context when they say excess deaths, and not just look at the past couple of years. So mathematically, that's my assessment for that, the excess deaths. Now, ventilators and medical involvement. This is something that is it's a huge thing that I have against death recording in general. And it's because it started with me actually fighting for the doctors against the health department, because the doctors, I would get worksheets back that would say that the underlying cause, the last thing that was listed was overuse of opioids or extended use of opioids. Wow. And I would try and submit that, and the health department would kick it back and say, doctors can't give medication as a reason for death. They're not allowed to. The coroner's office has to. So the coroner's office has to investigate. Now, from a more, what's that?
Because it's not a natural cause, so that's why.
Not a natural cause, right. So, and that's the big thing, is that the whole system is based on a very limited freedom of the doctors to give their medical opinion, and only the natural causes of their medical opinion, which doctors have medical opinions that things aside from natural causes are causing illness in their patients all the time. So they should have the freedom to say overuse of opioids was really the underlying cause in this person. But I had to go back, and this happened to 3 doctors within the course of a couple of months, that they gave me opioid reasons for death. And I tried to fight it with the health department, and they said, no, it has to be a coroner case. And I'm like, the coroners are just, all the coroners do, if there's no sign of foul play or trauma, is they just take pictures of the body, or the Los Angeles coroner, which is the biggest coroner. I mean, they're the most populated county in California, which is the most populated state. So the LA County coroner, they'll do a sign out coroner case, which is just, they come and they take pictures of the outside of the body to see if there's any foul play. And then they look at the person's medical record, and they'll usually just pick they'll even just come up with something. They'll say atherosclerotic heart disease. That was typical on sign out cases. It's just atherosclerotic heart disease. It means you have an old heart. That's it. And so that would be what the coroner did. Even when there was other things on the medical record that they could have picked as a natural cause, they're just going to be atherosclerotic heart disease. That was their go-to. So that's hugely problematic, because I knew that as soon as it was out of doctors' hands, we were going to get most likely a less accurate cause of death from the coroner, because they weren't going to do a full autopsy on this. This person had been attended. There was a medical record. They were just going to look at the medical record, take some pictures of the outside of the body, and be done with the case. So I would try and fight it. And every single one of the doctors, I had to call back and say, I'm so sorry, the health department's not going to let you put that. If you want to keep it on there, it'll just become a coroner's case. The family will have to wait 2 weeks while the coroner gets to us on their list, and their services are going to be delayed, and all of these things are going to happen if you leave it on the death certificate. But you're allowed to, doctors are allowed to leave it on the death certificate, and we just report it to the coroner, and the coroner takes over, and the coroner does the death certificate.
Wow.
But I had to kind of explain to the doctors, it's going to create a really big problem for the families, and the coroner's likely not going to do any kind of investigation. So it's up to you what you want to do. But that's the reality. And they would say, all right, take it off. They had whatever, and they would give me like a natural cause of death. And now that doctor forevermore knows that they can't put medications on the death certificate. And that is that's a big deal for scientific statistics.
And so
That's
you're
huge.
saying the opioid crisis, which was so shocking in the many that died, it was probably much more significant as far as, and that's for pharmaceutical induced deaths generally, probably.
Yeah. So the doctors, I think, have just learned, and usually if you're a doctor, a primary care person or hospice or whatever, or hospitalist too, you're going to learn within a few years what you aren't allowed to put on a death certificate. And then you're just going to go with the flow. You're going to do the natural causes. But that brings up the ventilator issue, right? Is we have, even for doctors, that their medical beliefs are individually crafted for themselves, and they do have their own independent beliefs about that patient might have died because of medical mismanagement or whatever. They wouldn't have the freedom. They would know if they've done more than 10 death certificates, they don't have the freedom to put that on a death certificate if they wanted to, and it will just become a coroner's case, and the grieving family is going to have to pay more, capitulate, put natural causes on there, and just move on. So we have a problem that we're not allowing doctors to actually have the full freedom of certifying a death certificate with both natural and unnatural causes of death. I think that's a foundational problem that we have in death recording that we're not going to get. And I've had situations with the coroner's office where there was a medication change with a relatively thriving patient, medication change a few days before death, and the person died, and the doctor said, I don't know why this person died. And so we tried to report it to the coroner and said, look, they had a medication change. The family thinks that this needs to be investigated. And the doctor says they don't know why they died. And the coroner says, it wasn't the medication. Over the phone, they were yelling at me. I had to talk to the lieutenant. And even then he got mad at me for trying to report a medication death. And I said, this is your job. Your job is to investigate. I am supposed to report this to you. And your job is to investigate. And I'm getting yelled at for wanting to report a medication death to you, or a potential medication death. So there's problems in the system. The coroner does not have time to look at these medication deaths, vaccine injury deaths. They don't have time.
And ventilator associated iatrogenic deaths would be the same, right? It would have to go to the coroner, and it's unlikely that they would identify that as the cause.
Medical defense. Right. Right, because anything that really what they basically say is that why you were given the medical intervention, that's the underlying cause.
Yes.
So you were given the medical intervention for COVID, it's COVID that's the underlying cause of death, not the ventilator, not the catheter replacement, not the infection that happened from the catheter replacement. It's, it's not the medical intervention that caused it in their way of doing protocols. It's why did you need that medication? Why did you need that ventilator? Why they go backwards, right? So, and it's always defaults to the natural cause of death, which is completely unscientific, very biased. And even for doctors of good faith that would want to start being more accurate on, they did have this intervention and this intervention, those were risk factors that may have contributed, and they want to put that down so that science has that out in the universe to look at. They can't. So we just have and that's before COVID, right? This is all before COVID. That's just the protocols in the system. It's broken. It's a broken system.
But isn't part 2 for writing down comorbidities or pre-existing conditions? But you're saying that doesn't really connect it to the cause of death in part 1, right? You just
right. So that doesn't it's there, so researchers can get to it if you put it in part 2, but the same rules apply. You can't put medications in part 2. You can't put fall. You can't put everything that would get you to the coroner's office before in part 1. We'll make it the coroner's office in part 2 too.
Okay.
So part 2 still has those restrictions. Yeah.
So the mind-blowing thing you've helped me to come to, correct me if I'm wrong, is that when we look at mortality statistics and we look at the evidence before us, it's really based on very little, if any, objective scientific validation, because it is supposed to be the opinion of the physician or the coroner. And even then, they're not really necessarily able to even always give the advice or share the perception of what is the underlying cause in the case of opioids or something else. So it's reified, meaning like we think that these provisional death counts, for example, are like rock solid, and health policy is now being written around those stats. But when you go drill down to these death certificates, it's really not the case, right? It's not really based on that hard evidence we assume is there.
Right. And I think that after reading a lot of historical literature on, medical literature on, kind of on PubMed, you can kind of see the timeline of how much things are, all like the research timelines. You can kind of click through and be like, read everything. And so I love kind of getting a historical picture of things, but you see this, it almost doing all the research, the health research I was doing before to find out about infectious disease and health choices around them before COVID even happened, really prepared me to understand what's happening with COVID in context. The exact same thing is happening. We're changing definitions. They're trying to adjust what gets diagnosed, and how we're diagnosing things. And the data is it's getting manipulated like that. And this happened like with rubella. The rubella epidemic happened when 2 years before scientists wanted to know how much rubella was happening. So they asked doctors to start mandatorily reporting rubella, and it says so on the MMWR, and so they started asking physicians, please start reporting rubella cases so that we can understand the prevalence of rubella. So physicians reported it. And all of a sudden there's a spike in reported cases because they were asked to report it. So we see this happening over and over where beliefs are changing and data gets asked for in a certain way and kind of coached. And then we create these public health beliefs of probability and problems based off of that, and danger and risk and all this stuff. And then, it just doesn't make sense. In the end, it's really just, when you look at mortality statistics, you're really getting a snapshot of how medical beliefs have kind of changed and assumptions have changed over the years. And so, and how technology has changed. We can actually, we call something Alzheimer's disease now because we can say what Alzheimer's disease is, or we're able to test for diabetes now, and it's not sudden. There used to be an acceptable syndrome that you put on a death certificate called sudden adult death syndrome, just like sudden infant death syndrome. Doctors could put sudden adult death syndrome before. That could have been for anything, but we've learned more. The beliefs have changed, and we're in this like micro unit study of that exact historical machine of how that works, right? Is that these public health officials are trying to get data, and so they're telling doctors to do things in certain ways, so doctors are doing them, and it's generating all this mortality data that now is creating a stronger belief in the medical community and enforcing a assumption before. And so now we're enforcing an assumption. It's becoming a more hardened belief, and that this has all happened in a year. And it's happened so many times before in other infectious disease histories. It's not out of the blue. I mean, unfortunately, it's not out of the blue, and you can kind of, look up, kind of match up, the trace paper and be like, oh, this is what's going to happen, kind of thing. So I don't think that it's unusual in some contexts when you look at historic infectious disease data capture, but I think it's a great wake up to say, hey, we have data capture issues, both in death data capture, but just so many different data capture issues going on, safety data capture, we don't really, they're not these perfect people that are making perfect scientific statements, and their statistics are really kind of making that hilarious, phrase come true. Like, what is it? Um, there's lies, there's damn lies, and then there's like, yep, this is like, statistics are the bottom of the food chain as far as scientific thought goes.
Wow.
So I think it's a wake-up call. It's a wake-up call for everybody to kind of really realize that whenever you try and use any form of data that's been captured by human beings within bureaucratic systems and things like that, you're just, the quality belief you can really come out with is going to be a really cheap quality. You're not going to get good quality beliefs from, this kind of, this government. I'm an information grunt. I wasn't, there was no, I only thought about things because my parents taught me to think about things, and I have a background in philosophy, and so I learned to think about truth claims and analyze them. But that's not what the average person does. The average death certificate person just wants it off their desk too. They don't care. They don't care what goes on a death certificate. They just want it done, and they don't want to get in trouble from their boss that the service got canceled because the death certificate didn't get complete. So the mortality statistics systems that we're creating are just not, they're not based on good quality investigation or unbiased thinking or unbiased freedom.
Yes.
Given to our medical providers and thinking insults.
Wow. Now that's so beautiful. So wait, now given we've discussed all this, I still want to better understand, last thing, the 6% statistic. Is it really then not what many of us thought, meaning that it was sort of like an admission that there really isn't that much there? It may be more an artifact, like you say, of the reality of people in a rush. This was the default guidance, is if the death, just write COVID-19. So, and then the other ones, the same thing applied. They were just more diligent, and they included the other.
Well, I think it's going to take a much deeper investigation. I think that what it shows that people were looking at this story so much is that they really want the truth, and they want better data, and they want true beliefs based on really good data. But the problem with the 6% data is that it's not what we think it is. It is just COVID-19 being listed on a death certificate by itself is much more just a little case study into the bad training that physicians get on how to fill out death certificates. Because if you click on the data that the CDC offers, some of the comorbidities are sepsis, cardiac arrest, respiratory failure, ARDS, things that COVID could have caused, and the doctor could have just put cardiac arrest, from ARDS, from COVID. So the doctor was just filling out the timeline more thoroughly. But then that's considered a comorbidity. So what people really want to know is, out of the death certificate data, which ones had the long-term conditions? So we need to be looking at everything that was a longer-term condition than the COVID diagnosis.
That's in part 2.
So we need Alzheimer's disease, chronic kidney disease, cancers. We need the chronic condition data. And we do need that. We need to figure out what that was. But doctors also don't put that. If they got their underlying cause on there, they're going to get their death certificate approved. So they don't have to put anything else aside from COVID. If they put COVID on there, they don't have to put anything else. It's done. The death certificate's done. It's off their desk. So if the doctor did put underlying conditions, that'll be great. But figuring out the percentages from death certificate data, we're not going to get it. We need a deep investigation of the medical records and the medical treatment of each person that died from COVID. And we need independent investigators, independent physician investigators looking at the medical record and understanding the context for each patient and giving a second or third opinion of what caused death. And I think that really intense data investigation would give us the most accurate beliefs. Anything off the death record data right now is just To me, it's honestly trash.
Well, no, that's
It's
super helpful
depends on
because,
the doctor.
yeah, because I think that initially many of us were like, okay, here's a slip up. You know, they admitted what we all believe, which is, you know, that no, COVID-19 isn't the sole cause of these so-called deaths. But on a deeper level, you've confirmed that what we believe, you know, is really evidence-based, solid death certification is really not based on that much solidity, if any, and that's through the guidance from the World Health Organization, the NVSS. It's assumption or suspicion of infection is all that's required to code someone dead from COVID-19, from what I've seen. Is that correct?
Right. I mean, I think that the best evidence that we can argue from death certificate data that these people had underlying conditions that actually were more properly pre-COVID death recording, more properly to be said to be the underlying condition in our usual protocols before all this, is their age. And that is a scientific fact, right? So that is one of the scientific facts from death certificates, is their age, their place, their name. You know, those are scientific facts. So the age bracket is a really important factor from death certificates, and that's something to look at on the provisional death data, and to be able to say that the vast majority of COVID deaths are over 65 years old, vast majority. And then just a huge, I mean, I think it's like a 1/3 chunk, or, you know, 1/3 or 1/2 chunk at this point is over 75 years old. Our projected age of what is it? Our life expectancy is 74 in this country. So you're literally expected to kind of have an average life 75 years old.
Yeah, exactly.
So, and that's not, I'm not taking people's death lightly.
No.
I'm talking about the numbers of, and probability, the mathematical probabilities that we're talking about of, are the people that are dying people that actually would have had, they absolutely would have. They would have had something they were on medication for. And this happened all the time, even for people that they weren't under hospice care. They seemed pretty healthy, and they just passed away at home and nobody knew why. We would, the coroner would take the case, but they would just do the thing where they take pictures of the body and they call the recent primary care physician, find out what medication that person was on, and that medication, the cause of them being on that medication, hypertension or, you know, COPD, that was their cause of death. Simple, done, coroner's done with it, you know? And so it's whatever you're on medication for. After you're 60 years old, it's whatever you're on medication for is your cause of death, if they don't know what else caused it. So, you know, that's really where we should think. We should think, where would these deaths have gone before? It would have gone bumped back to their underlying condition. So, and we know because of the age of death that's happening with COVID, that is a scientific fact, that these people do have comorbidities in the sense that we civilians understand, but underlying conditions medically, right? That would have explained their death regardless of what infection they died from or what caused dying at home for no reason before. So we can I think that it's a legitimate hypothesis to say that based on the age of death, the majority of people, maybe even 94%, who knows, but the majority of people that died, it's a legitimate hypothesis, but not based on the not based on what the causes were, but based on the age, if that makes sense.
Oh my God, so helpful. And what you revealed about, it was 2014 to 2015, you said the excess deaths were something over 200,000?
Huge jump in 2008. Someone shared, when I shared that post on my Facebook thing, they shared a bigger timeline of mortality, you know, increases, excess death, things. And there was this huge jump in like 2008 or something. And I was like, well, what was that from? They're like, oh, well, maybe it was the economic crash and the suicides and I was like, oh, that's an interesting, you know, thing to look at. But excess deaths have been happening every year. We've been having more and more excess deaths. So you just have to look at the brackets.
You know, if they control for the natural population growth in the United States, do they at least do that, or is that not even big?
I think it's per 100,000. I think it's that kind of excess.
Wow, but that's, oh my God, Joy, this has been so helpful in providing context and, removing some of the hyperbole and, the self-fulfilling prophecies that we have around this information, just to get some facts into the conversation again. So I'd like to ask you too, like, where do people follow you? Is it through Facebook? Is that the primary way to follow?
I do, just because, I mean, honestly, I think critically about things as a hobby. So I'm not I don't really I mean, I do have a Patreon thing that a few people are really sweet and they support me, so I get a babysitter once in a while for videos like this.
Oh, that's great.
But I don't really push the monetization thing, because for me, I'm a mom, and that's my most beautiful role, and I love that. I'm a critical thinker. I'm a philosophical thinker, and I think that it's just about, I am on Facebook, so I did create that public page to create some space from my private page to have civil discourse on health issues. So I do have a public page on Facebook. It's called Joy M. Fritz, The Untrivial Pursuit. I'm also asking people where else they want me right now because of all the censorship on Facebook. So I kind of took a poll on that. I might be on MeWe or Parler, these other ones. All kind of, but I am on Instagram and Twitter. I don't really update those a bunch. I've got 3 kids and 1 more on the way, and I homeschool, and life is so beautifully full right now. It's an honor to kind of be part of the discussion in this historical time of the importance of data capture.
Totally.
And we really, as citizens, need to demand for better data capture, and we deserve it. We deserve accurate, true beliefs, based on good quality information. And to me, that's what I'm fighting for as I research health information. I just want good quality information, and we have so many broken systems. Death data is only one of them, but so many broken systems where we can't even form good beliefs, like even one way or another, because there's just not the good information there. So we're forming a lot of hypotheses either way, right? For or against something, but there's really not really good foundational beliefs. So I hope that the stuff I share on my public page is helpful to get people thinking and asking questions. And I love your stuff because it gives a lot more well-referenced. I try and reference, actually, you were a good example to me. I try and always make sure I include my links to my studies I talk about. So people don't say, well, she's saying that, but she's nobody. And I'm like, yeah, I'm nobody, but if nobody does anything, nothing will ever happen. So I'm going to be a nobody that does something. So,
you're a big somebody.
But yeah, I enjoy it, and people want to follow me there.
That's awesome. We'll have the links to all those ways to connect with you, including Patreon. I would highly encourage people to support your work. It's very meaningful. And I just want to thank you so much for your work. In fact, one last thing I'll say is I got the vision that I would love for you to just produce some type of book, even if it's just a couple hundred pages, with the combination between truth seeking, the philosophy background, and understanding data capture, especially with, COVID as a use case. That could be so enlightening to people. I've seen people do these books and put them on Amazon, and they're bestsellers, because in this moment, we need this help more than ever before. So I would encourage you to consider that after, you create more amazing life on this planet. But thank you so much for your time. And
people are leaving social media in droves right now because they're so fed up with not being able to get good kind of, good conversation, good civil discourse, good information. So, it's tempting to me to kind of be really organized about it and really get the information explained. So I appreciate that encouragement, and it might be something that God will give me the time to do one day.
Hope so. I would love it. But either way, what you've contributed, even in this conversation alone, has been priceless. So thank you so much. And just wishing you the best in the transition to being a mom of another beautiful child. So thank you again.
Thank you. Thank you so much. And thanks for your time. This was fun.
Thank you. All right. Bye.